you can't have a talk from my sort of drug oncologist without talking about targeted therapies. For us, they're the way of, they're here now, and they're clearly the way of the future. Just to give you an illustration, looking at that pathway from the back of the room, you might think, crikey, that looks complex, there's squiggles and names going everywhere and there's little nodes. Well, on closer inspection, that's the London Underground. And we know that even though it looks complex, and it probably is, even though we know it looks complex, once people understand all the links and so on and the timetables, it's actually understandable. And that is, I wouldn't be so arrogant as to say we understand the human body as well as we do the London Underground, although people who've travelled in London might argue the toss that nobody understands the Underground. We can look in the human cell and we can understand some of the pathways and linkages. And this is an illustration of but one cellular system that sort of starts at the surface of the cell. So that's the surface of the cell, and we've got the nucleus in here with the genes. I'm sorry if you hear people over there. I can't point in two places at once. You need a radiation oncologist, they'd be able to. And normal chemicals come in and activate what's called a receptor on the cell surface, and that receptor then communicates into the cell where it's got a little tail sitting in the cell, and that triggers a cascade of chemical reactions and so on. And a lot of them end up in the genes, telling the genes what to do. So this is normally a very regulated process. You know, our body's got a yin and a yang for everything in the body. But in cancer, some of these cellular processes can be overactivated. They're switched on and they don't switch off. And most of them are driven by mutations within the genes. So the genes send out messages to say, right, activate this or activate that, and away we go. So we've been able to develop targeted therapies that get inside the cell and switch off some of these processes. Just briefly, one group of targeted therapies are what we call small molecules, and they get right in the cancer cell, and they're trying to switch off these chemical pathways to quieten the cell down. Now, of course, the challenge, as you'll remember from the previous slide, there's multiple chemical pathways. So often the cancer will sneakily work around the block that we've put in place, but it's a step forward. Sometimes in the setting when there's a single driver mutation, and that cell's relatively simple, and the examples I've got there are CML or chronic myeloid leukemia, or GIST, which is a rare form of gastro-intestinal stromal tumour, have a single driver mutation that is switched off like magic with a targeted therapy. This has led to a variety of side effects because these drugs aren't like the standard chemotherapies that we've been using for 30 or 40, 50 years. They've got more specific and different side effects which cause us headaches. But by and large, compared to chemotherapy, a lot of them are much, much better tolerated. The human body generally tolerates them very, very much better. The upside, though, is we see some spectacular responses. Some of these that have got a driver mutation, the cancer just melts before our eyes. And in some types of cancers that we really hadn't seen that sort of thing before. The other form of targeted therapy that really is very exciting is immune molecules. So our immune system makes all these molecules that are trying to fight off foreign things in our body. The clever scientists have actually made the identical immune molecules in the laboratory that can target things on the outside of cancer cells. So I'm sure it's probably a bit hard to read from the back of the room, but there's an increasing number of cancers that have got a particular target, and these are the range of cancers. So of relevance to tonight, there's EGFR in colon cancer and VEGF in colon cancer that can be targeted by one of these antibodies that are usually given by injection at regular intervals. And by latching onto the outside of the cancer cell, it often quietens the cancer cell down. It sort of blocks the processes. But the other really crafty thing these immune molecules do is they've got a little tail on them. That's what you call the tail region. And so when the antibody or immune molecule latches onto the cancer cell, the tail's sort of sitting up in the breeze. And the tail attracts the other immune cells into the neighbourhood. Because the cancer's busily trying to tell the immune system to go away. Well, these antibodies say, hey, come over here, something going on here. And the immune system becomes much more interested in the cancer cell, interested in a positive way, in that they can set about destroying the cancer cells. So, but I've got to tell you about what we think is one of the most exciting developments in our specialty of medical oncology are these immune molecules that are on the bottom of the slide. And what these do is tell the immune system to ignore the cancer cell in trying to tell the immune system to go away. So you've got a cluster of cancer cells. They're sending chemical messages to the immune cells that are sniffing around to say, nothing to see here, move along, go about your business. We've got now these monoclonal antibodies or immune molecules, and they're in our clinic now for some types of cancer, that can actually block this cross-chat. And so all of a sudden the immune system is activated right in the neighbourhood of the cancer. And so particularly in people with melanoma, but it's now extending to lung cancer, head and neck cancer, some subtypes of bowel cancer, we're seeing some quite dramatic tumour shrinkages with these new immune molecules. And so they're immune molecules that are working on part of the immune system, go figure. But it's one of the most exciting things that I've seen in my career. So the end result of all this, where we're working towards, is to take a population of people that look the same, their cancer looks the same under the microscope, but there's some quite fundamental biological difference, and we're trying to better separate them into biologically similar groups and treat those groups with the most appropriate treatment for their type of cancer. And I've got some examples there of the immune therapies, the anti-EGFR antibodies for a particular group, BRAF inhibitors for another group, and this is the way forward. But we'll only continue to make these advances by doing good clinical research, and this is where our community and our patients come to the fore by helping us all to answer the big questions. I think we owe it to our community to get this right. Cancer care is too important to sort of go off half-cocked on a warm feeling, and most, if not all, of the important advances that we've made to date in cancer care, and I say that in the broadest sense, have come through good ethical research.